Let me ask about the patient-centered primary care contract for the state. I will tell you, I was a little bit surprised to learn after the contract was issued that the PC3 contract provides that the contractor may set the reimbursement rates for the care that's referred outside of the VA system. But as you know, we don't have managed care within the state. We've got more patients than providers, as I mentioned, and providers reject managed care. TRICARE does not allow its contractor to set rates in the state. So when we learned that TRICARE was charged under its contract with negotiating rates in Alaska, again, it really gets your attention, really surprised you there. So we were told that when the PC3 contract was entered into, my staff checked with you folks at the VA to ensure that the contractor was aware of the need to pay market rates there in the state, and we were assured at the time that the contractor knew about that. But what we're beginning to get now are complaints, and I will acknowledge that there's sporadic complaints, but complaints that the providers are not getting market rates. We heard just recently from an anesthesia group that was very frustrated in working with the PC3 contract and is considering no longer serving our VA patients, which of course is exactly the opposite direction of where we want to take this. Is this something that the VA is monitoring?
So I don't know about the PC3 contract and Alaska provisions per se. I wasn't really involved with that at the time the PC3 contract was constructed, but I will go look at that. I will tell you that I think you're raising probably one of the most significant issues we face, and it's not just for Alaska right now. I think that one of the things that we are doing, really prompted by the choice legislation, is to ask kind of ourselves, what is the future of purchase care in VA? What does that look like? What does a VA health plan look like? We have employed Deloitte to help us do an assessment of our current purchase care processes. And I think we have a whole smorgasbord, quite frankly, of options, from local contracts to the spot market to sharing agreements to PC3 to Choice, to Project Arch.
And they can be different all over the country.
And they're different all over the country. And I think one of the things that we are going to be doing over the next few months is sitting down and saying, how do we reconcile all of this? And quite frankly, Tri-West tells me almost on a daily basis what an awful position we have put them in, because they are going out to the same providers that we're contracting with, saying, would you like a PC3 contract? And oh, by the way, we have a Choice contract over here. And it's mind-boggling. Yeah. So we definitely have to resolve this. I think you've hit the nail on the head.
Well,
if I could just make one point.
To look at not only Alaska, but look at across the system, because it just doesn't seem to be trending right here for us.
We would not want one size fits all, right? Because the markets are very different. Right. Alaska is going to be very different than Wisconsin, for example, or New Mexico. They're just very different constellations, ecosystems, if you will, of medical services. But at the same time, we have a lot of work to do to try to rationalize this, because if it's illogical for us, it's going to be much, much harder to give veterans a seamless, terrific experience every time.
Yeah, appreciate that. One last question, and Dr. Clancy, we were trying to connect yesterday as I was traveling cross country, and we weren't able to do it, but I think you were alerted. I had read the op-ed piece in the Washington Post this weekend by the former Vice Chief of Staff of the Army, General Chiarelli, suggesting that the VA's mental health drug formulary is just too narrow to ensure that the medications that Department of Defense provides, when that individual separates and then moves over to the VA side, that they can be maintained after he leaves service. Now, it is my understanding that you have attempted to address this through regulations. General Chiarelli suggests in his op-ed, in fact, is pretty emphatic that the regulations aren't sufficient, that they leave broad loopholes. Can you kind of tell me where we are with this? Does he have valid concerns here?
So first, given his work and interest in mental health, traumatic brain injury, and so forth, I mean, I have huge respect for his contributions and building awareness of these issues. What I can tell you is we're working very closely with the Department of Defense to assure as seamless a transition as we possibly can for service members who are leaving the military and coming to VA. As a result, in particular, of the executive action issued by the President in August, focused on improving mental health care, a whole series of actions. We actually have directed all of our facilities and clinicians that service members can continue their medications at least until they can have time to be evaluated by a clinician in VA. Some drugs that are good for short-term treatment may not be the ideal choice for longer-term treatment, and it's often very common with the chronic use of drugs to treat different mental health disorders that you're going to need to make changes. You know, one antidepressant works for a while, but then doesn't work so well, and so forth. And we do that for other medications as well. We'd be happy to come and give you a full brief on that. I think a little bit of what happened was that the commission was, that General Chiarelli was working on, which has just delivered its report to the Department of Defense, the Military Compensation and Retirement, I can never remember the entire acronym, was working independently as they very much wanted to at the time when this executive action and other activities were in process.
Well, I would be curious to know and understand a little bit more, because I thought, at least the way that the general had outlined it, it appeared that we were not syncing the systems, and when the systems don't line up, then it's the veteran and the veteran's care that suffers. So, I don't know whether he's correct in that we do still have loopholes that need to be addressed, but if you can provide me with a little more information on that. Has the department been in contact with the general about his recommendations, do you know?
I've been trying, but have not managed to connect with him yet.
All right.
He is actually part of the Blue Ribbon panel that is reviewing all of these independent assessments, but cell phone land didn't make it possible.
All right. I appreciate